Thanks for joining us today. This is the second edition of the NERG MKRC Neuroscience Journal Club. My name is Michael Kortz. I'm in between my third and fourth years at Kansas City University, completing a research fellowship in neurosurgery at the University of Colorado. I, along with Edwin McRae, he's in between his third and fourth years at Campbell University, completing a similar fellowship at Duke. And quickly, just a quick blurb for those of you who aren't with us for the first time. We've started this group called Neurosurgery Education and Research Group, NERG for short, really aimed at improving neurosurgery education, research skills training, and professional development for younger students in their first and second years in medical school, mostly. It's been a great success so far, and this journal club is an extension of that. And a manifestation of that. So enough about that. We're going to get right into the article discussion for the topic today. And we have Gretchen Koller. She's one of our amazing NERG members. She's a second-year med student at Kansas City University. She's one of our inaugural members. And she's working on a project with us looking at residency match success in neurosurgery, as well as some other things. She graduated from the University of Missouri Columbia with a Bachelor of Science in biology, and that's where she also conducted some research on proinflammatory mediators and their effect on capillary tube regression. Her and I have had a couple conversations, and she's definitely interested in neurosurgery, but I think she has a healthy outlook on it, and she's still learning a lot about the field and associated things with it. So she's just in the mindset of learning a bunch about it, and I think this is a good way to do that. So, Gretchen, without further ado, why don't you take over and get us started?
Yeah, sure. Thanks, Mike. Okay, well, let me try and share my screen. Thank you, everyone, for being here. I know we're all really busy, so I appreciate you all taking the time out of your day to be here.
Gretchen, I'm just going to quick say one thing. So if anyone has questions, just please don't ask during the presentation. You can just raise your hand or use the chat feature. I think Shelley and Dr. Staudinger will host the questions after Gretchen's talk. But that's just to help her, certainly in the virtual format, where that's the way we're going to try to do it. So just wanted to make sure that that was said. So sorry,
yes,
Gretchen.
thanks, Mike. We'll field them at the end. Thank you.
All right, sounds great. Okay, pick this up. All right, can you all see this?
Yes.
Okay, great. I can't see you guys, but okay. All right, so thanks everyone. We're going to be talking about intrauterine intervention for neural tube defects today, specifically the management of myelomeningocele study, or MOM study, and then the article that was sent out that goes over some of the outcomes and some more sub-analyses of the original MOMS trial. So let's get started. So what is myelomeningocele? Myelomeningocele is, it lies on the disease spectrum of spina bifida, and it's when the meninges in the spinal cord both herniate out of the spinal column and into a cyst-like sac that's located on the baby's back and is filled with cerebrospinal fluid. So this spina bifida happens when the posterior neuropore, that's kind of shown here, doesn't quite close all the way during development. So that opening there leads to either spina bifida occulta, which usually some people don't even know they have, or it can lead to meningocele, in which just the meninges here and here kind of herniate out into the exterior, or what we'll be talking about today, meninges and spinal cord here in the yellow herniate out into the sac. So this does occur in about 3 out of 10,000 live births in North America. Unfortunately, that is much higher in low-resource populations such as South Africa and Southeast Asia. There is about a 10% mortality rate, and those that do survive typically have irreversible paralysis of the lower limbs, and/or bowel and bladder dysfunction. A few main complications that are worth noting are Chiari-2 malformations, which include hindbrain herniation or brainstem abnormalities, and hydrocephalus, which is buildup of excess cerebral spinal fluid within the brain or spinal canal. There really is no prevention for this outside of the regular recommendation of pregnant mothers to supplement their diet with folate. Okay, so kind of the background of what we're going to be talking today is based off of this MOMS trial that I kind of alluded to earlier. So in this trial, over 1,000 women whose fetuses have had myelomeningocele abnormalities were screened, and many of which were excluded due to predetermined criteria. But out of that 1,000 women, about 183 were taken into the trial and randomized into a prenatal group, which received intrauterine surgery, or the postnatal group, who received the repair within the first 48 hours after birth. Mothers who did undergo the intrauterine surgery, they had that before 26 weeks gestation and were to remain near the hospital until their scheduled delivery, which hopefully would have been full term, but as we'll see later, wasn't always the case. So here's just kind of a quick schematic of how it goes. Here's the fetus in the mother's belly, and the uterus is opened to visualize the defect, and then surgeons are able to incise that defect and stitch it back up and put mom and baby on their way. So some of the main results from this original trial. First was the decreased rate of shunt placement in the prenatal surgery group. So there was about 82% required a shunt in the postnatal group, and by having the surgery, they were able to cut down that rate to about half, so about 40%. There was less degree of hindbrain herniation, and again, almost every child in the postnatal group required or had some kind of hindbrain herniation, and that was also decreased in the prenatal group. And more importantly was the fact that almost 36% of the prenatal group had no evidence of any hindbrain herniation at all, whereas there's only 4% in the postnatal group that had that. They had less brainstem kinking and a lesser rate of syringomyelia as well. So these results in the chart were at the 12-month checkup, and they also had 30-month checkup as well. And they saw that there were improved mental and motor function and increased ambulation as well. So as the ability to walk was more based off of the level of the lesion, but it was seen that the children in the prenatal surgery group were more likely to be able to walk without orthotics or any kind of assistant walking devices. So 42% of them were able to walk completely independently, whereas only 21% in the postnatal group were able to do so. People postulated that the improvements were probably associated with the timing of their repair, meaning the spinal nerves were not exposed to the external environment or the amniotic fluid for as long of a period of time. So this allowed for more normal development of the nervous system prenatally. Reductions in shunt placement or the need for shunting in the prenatal group was probably due to the reduction of hindbrain herniation. So without that blockage of CSF, there were less rates of hydrocephalus and the less need for an actual shunt. So because of all of these positive outcomes, as you can see here, the trial was actually terminated early. The original plan was to have 200 women and their fetuses undergo either prenatal or postnatal surgery, but they were seeing all these awesome effects and decided that it was unethical to actually continue to only operate on these children after they were already born. So instead of the original 200, only 183 were actually part of this trial, or at least part of the analysis. So with that, sorry, my cat is here as well. With all the outcomes, there are some drawbacks. The main one, which is maternal membrane complications. So One of particular notability is the chorioamniotic membrane separation. So the chorion and the membrane are two very thin membranes that are kind of fused together. And as you can see, this occurred in 26% of those who underwent prenatal surgery, but did not happen at all in the postnatal group. It's thought that this is because of the trocar that's used as the initial incision for the uterus, and that kind of caused like a tenting between the two membranes, which would eventually lead to complete membrane separation. This would also lead to spontaneous membrane rupture, which is kind of when your water breaks, but your body's not ready to go into labor. So this did lead to an increased rate in spontaneous and preterm labor, and also an increased rate of oligohydramnios, or not enough amniotic fluid within the cavity. So again, this led to preterm delivery with an average gestational age of 34 weeks in the prenatal group and 37 weeks in the postnatal group. Also of importance was this very premature group down here, less than 30 weeks old. 13% of the prenatal group were actually born that early, whereas that didn't happen at all in the postnatal group. Okay, so the article that was sent out to you all today, the surgery for fetal surgery for spina bifida. So it recapitulated all of the original results that I have just gone over with you, but it also had some more sub-analyses, and that was able to include the entire cohort. When the original mom study was published, not all of the children were 12 or 30 months old, so they weren't included in the analysis. But Tulipan et al., he was able to analyze all the entire cohort at 12 months, and they essentially supported the original results regarding rate of shunt placement or a need for shunt placement. And they also found that ventricle size actually correlated more with the prenatal group needing a rate for shunt. So if they had, within that group, 20% that had ventricles that were less than 10 millimeters, they required a shunt, and 80% that had ventricle sizes greater than 15 millimeters required a shunt. That dramatic difference wasn't quite seen in the postnatal group, for with them, just about 80% of the total group required a shunt regardless of their ventricle size. Farmer et al., they did the same thing, but for 30 months, so they analyzed the entire cohort, supported the original results, meaning that prenatal repair improved motor development and reduced the rate of permanent CSF diversion. So a couple post-MOMS clinical trials that were going on, two of which are important is Vanderbilt, and one that was done at CHOPS, which was the Children's Hospital of Philadelphia. At Vanderbilt, and I'll go into this in a little bit later, but they kind of modified the technique, which led to a decreased rate in the premature rupture of membrane, a decreased rate, well, none at all for the membrane separation. And CHOP had decreased rates of oligohydramnios. And due to the decreased rates of the membrane complications, mothers at Vanderbilt were able to undergo full-term gestations at a greater rate rather than the 21% who were only able to carry to term in the original mom study. They also had less that were born very premature. And so what actually was going on at Vanderbilt, and what does the surgery kind of look like? So with this schematic, there are a lot of people that are needed to pull this thing off. It's definitely a team effort. You have maternal fetal medicine, who kind of have an idea of what's going on with mommy and baby. You have pediatric neurosurgery because we're dealing with the spine, neonatology, pediatric cardiology over here. They're constantly monitoring the heart throughout the entire procedure. We have plastic surgery, anesthesia, who's taking care of mommy and baby. And then outside of that, you've got operating and nursing staff. and sonographers. So it definitely takes a lot to pull this thing off, and it's no minor task, that's for sure. So, so one day prior to surgery, mom gets admitted to the hospital, and they use this time to run some preoperative labs just to make sure everything's a-okay with mom and baby. She gets an ultrasound to kind of estimate fetal weight and get an idea of where exactly the fetus and the defect are within the uterus. So the day of surgery, mom gets general and epidural anesthesia. This just maximizes uterine relaxation, making sure nothing weird is going on whenever they get into surgery. So this is kind of what it looks like actually in the operating room. The uterus is exposed with a vertical incision, and so up here you see that the baby is being visualized with ultrasound, and they're getting more of an idea of where exactly the defect is, and they're monitoring the baby throughout the entire thing. And so what Vanderbilt did differently was, instead of using a trocar, they used electrocautery to actually open up the uterus and made about a 6 to 8 centimeter incision rather than puncturing with the trocar. So that's why they think that this was able to help. It didn't have that pressure on the membranes. There wasn't as much tenting going on. So once visualized, the fetus was also administered some anesthesia, and this just prevents it from moving around when they're trying to fix the defect. And again, so this is a little bit closer up. Once it is visualized, the plaque, well, okay, so first it's kind of, guys, this lighter pink around here is the mom's uterus, and then the darker pink here in the center, that's the baby and the baby's back. And then this tiny little kind of shiny circle in the middle, that's the actual myelomeningocele defect that they're going to be working on. So the surgeon incises the placode right along the epidermal and meningeal border. And once that happens, then the placode is able to, or spinal cord is able to just descend back into the spinal column. And for closure, if there's enough dura, they'll use that to cover up the defect. But more often than not, they use a synthetic graft, which you can kind of see here in the white. And after that, they can focus more on skin closure. So they'll just, again, if they have enough skin, they'll just use some running sutures. And if not, I think they'll get some skin from the flank. So after that, mom and baby go back to the OB wing, rest up, and then are allowed to go home until the end of her pregnancy, which is hopefully 37 weeks. But as I told you earlier, happens more often than not that she will deliver preterm. So where is this going? The future of intrauterine surgery. A big thing that's on the rise right now is fetoscopic repair. And so some of the early trials of this were not so successful, had some disappointing results, so it was kind of put on hold for a while. Up until Texas Children's Hospital developed a 2-port technique where instead of a large incision across the abdomen and across the uterus, they were able just to make 2 smaller incisions where they could put some ports into and manipulate the instruments through there. The whole point was to minimize the maternal morbidity that was being seen without affecting the positive outcomes of the open intrauterine repair. So as a preliminary report of the first 12 cases from Texas Children's, they saw that 70% of those infants were actually able to be born vaginally because the mother does not have a large incision that has recently healed. So there's no or less risk of it rupturing during a vaginal birth. So that's good. And then it also helps her dodge the need for another major abdominal surgery so soon. Some limitations for this is that there were some instrument wrist articulation issues and dexterity at the patient interface. But overall, there were only 25% of mothers that experienced the premature rupture of membranes. They saw a 90% reversal of hindbrain herniation. And so they had some really promising results. But since the cohort was so small, larger cohort trials are needed before this can be considered standard of care. But it's definitely heading in the right direction. So to help with this limitation, people have started trying experiments with robotic-assisted surgical systems, such as the Da Vinci, that I'm sure many of you are familiar with. You know, the physician sits over here while the actual surgery is happening over here. And it's even more minimally invasive, and it's already being used for different urological procedures. So they're hoping that this can be the next step in surgery, fetal surgery innovation. The end goal for these patients and their mothers is to hopefully eliminate completely hydrocephalus and Chiari malformations as complications, allow them to gain normal function of their lower extremities, bowel, and bladder. For mom, it would be to allow her to carry her baby to full term and have an uncomplicated vaginal birth. This together would allow the mother to remain at a normal risk if she should have any subsequent pregnancies. So definitely something to look forward to. So I thought this was really neat. I just found this a couple of days ago. It's actually a follow-up article of the original children who were operated on in the original mom study. So they weren't able to get everybody, but they were able to follow up with 161 of the original 183 kids. Now they're between 6 and 11 years old. And big picture is they're doing really well. So with this follow, they had all kinds of tests that would assess communication, independence with daily activity, learning, walking, reading, math, all kinds of stuff. So what did they find? One was that there's no difference really in adaptive behavior. So communication, socialization, stuff like that. The prenatal group did score higher on reading and sensory motor and fine motor skills tests. Interestingly, they were a little bit taller by an average about 3 to 4 centimeters. And they continued to show a lower rate of shunt placement and the frequency and higher frequency to walk by themselves. So this is Connor. He was one of the kids. You can see he's walking by himself. He just has these little leg braces that he needed. This is Connor a little bit later. Loves to play soccer, run around. This is Maya. She loves to play outside and has full function of her legs. She just can't quite control her bowel and bladder. But for her, this is completely normal. It's all she's ever known. Her parents have normalized it for her, and they just take her to the restroom every few hours. And that's all she's known. That's normal for her. And then this is Caitlin. She doesn't have as good a function as her legs with other people do, but that doesn't stop her from hanging out with her friends and doing things that she loves. So you can see that we've come very far in the treatment of this disease, and these kids are living relatively normal lives. And so it's only going to get better from here, and it's really exciting to see where the field can go in the near future. So this is all I have for you. These are my references, and I look forward to any questions you all may have. Thank you.
Thank you, Gretchen. That was a great talk. If anybody has any questions, we'll take questions at this time. Okay, well, I know I had one. I was curious. I know in the beginning you said that the only thing they can really do is supplement the pregnant mom with folate or something like this. Is that just something that's in prenatal vitamins that every pregnant mom would receive anyways?
Yeah, so it's kind of recommended that all pregnant women take folate. It's really important in like DNA synthesis and stuff like that. So just the development of the fetus itself. I don't know if it's in prenatal vitamins or not. Maybe someone else could chime in. I don't see why it wouldn't.
I can answer that. So, Shelley, it is in prenatal vitamins, but the folic acid or the folate is very important during the neural tube development, which is in the early stages. It's the incidents aren't as high in America because a lot of foods are already fortified with folic acid here. Although some people may still be somewhat deficient, it's less likely because it's fortified in the food. So if you started taking prenatal vitamins once you found out you're pregnant, you've been pregnant or likely before you knew. So if the food wasn't fortified, taking the prenatal vitamins starting then and the folic acid may not actually prevent the neural tube defect.
Okay, thank you, Eddie. We do have a question. Let's see. Molly, I see your hand is raised. Go ahead.
Oh, I think you're muted, Molly.
She looks unmuted on the participant list.
Yeah.
Is your microphone correct? Molly, we're not hearing you. You can put it in the chat. Do you have a chat function? Okay.
Text one of your colleagues on the call.
I was going to say, yeah, maybe she's texting it or.
You can text somebody.
Yeah.
Is there any other questions?
I think she's on the phone with student Dr. McCrae now. Does anybody have any other questions while he fields Molly's?
Oh, you gotta love technology. Dr. Wolf from Jack Thomas.
Hey Gretchen, that was really good presentation. Question for you, did you see why they had to do the surgery at 26 weeks or before or around that time? Was there like any significance to that?
That was Molly's question.
Oh. Okay, thanks, Jack.
Yeah.
Okay. So I think the main thing is they're trying to do it early enough to prevent further spinal cord damage. So they don't want to wait too late into the pregnancy whenever damage may almost already be irreversible. But they also don't want to do it too early because with like the skin and the muscles, just being able to actually hold on to the sutures. And many of these mothers don't even know that it's their baby has this defect until the ultrasound at like 16 weeks or so. So after that, it's also like a logistical thing, gives them a couple of weeks to like get to one of these hospitals and have this surgery as well.
Perfect, thank you.
And I think that's what Eddie was saying was Molly's question.
Okay.
Yeah, so I think you took two birds with one stone on that one. So let's see, I've got a couple of other hands. I see Brandon Bishop, your hand is raised. Go ahead, please. I think you're muted.
Dobson, Dr. Dobson.
Hey,
No.
thank you.
There you
I
go.
think one of the other limitations at younger than 26 weeks has to be size. You're talking about an intrauterine organism that's only 12 inches overall, so there's got to be some issue with size. Those ports on the Da Vinci machine, if indeed it is done that way, are about the size of your finger. So that's got to be an issue, I would think. I don't know because I've never seen this, but And Gretchen, very nice talk.
Thank you, Dr. Dotson. Very good point.
I see Dr. Schneier's hand is raised. Go ahead, Dr. Schneier.
Gretchen, hi, it's very good presentation. I know your background is inflammatory reactions, etc. So when those operations in the utero operations is done, can you just, because I'm not familiar, how easy is heal it with the fetal tissue? Anything what you will see in reading these materials, please?
Are you talking about the dural synthetic patch? Okay. Yeah. So if they can, they try to use the fetus's own dura, but sometimes there's either not enough or it's not strong enough. I didn't see anything about specific materials that are used, but they just talked about the synthetic graft that, especially at Texas Children's, where that was being used as well. I don't think that answers your question very well, though.
Probably it's because it was operations are usually done very early prior to the full capacity of immune responses of this fetus is kind of generated. So at that time, it's accepted everything as self, whatever you put there. All right. Mm-hmm. Okay.
Okay, thank you. I see Jack Thomas, your hand is raised. Go ahead.
So I've got a kind of two-part question. First part is, did any of the moms have to have a specialized diet like pre or post procedure just to ensure the health of the fetus continue growing? And also, maybe it's due to my lack of knowledge, but wouldn't some sort of invasive procedure be very stressful on the fetus? So did they do anything to combat that?
Okay. Very good questions. Regarding your first one about the maternal diet, I didn't see anything in my research that would require the mom to have change her diet in any way. So I can't quite answer that one for you. But the second one regarding fetal stress, is that what you're talking about? I did see something that it's kind of on the fence on whether fetuses this young can actually experience pain or stress. It's up for debate right now. So they went ahead and administered the anesthesia on the safe side for just in case that would happen and to kind of prevent any stress response from happening. But again, I think that's a topic of research going on right now, and they're trying to figure out whether or not for sure that's happening or not. But good question.
Thank you.
Thank you. I see Mike, I see your hands up. Go ahead, please.
Yeah, so I was just going to follow up a little bit on Dr. Schneier's question. So if I assume they're using the similar dural graft that they use in adult surgery, it's basically a DuraGen is the dural graft, and it's an avascular type 1 and type 3 collagen matrix that they use with a 10 to 20 micron neuropore that they strip all the cellular components out of. So the inflammatory response would be pretty minimal in terms of, because I know that certainly the concern in for fetoscopic surgery is the extra concern for a protected environment between baby and mom. And so if they're using the same dural graft, I would assume that it's that, and it would be, the risk is minimal, and I would assume it's no different than what it'd be for adult surgery. So
thanks for that, Mike.
Yeah, thanks, Mike. I see Dr. Schneier put his hand back up, so we'll let him comment too. Go ahead, Dr. Schneier.
Michael, thank you for this clarification. It becomes clear because collagen is not immunogenic. I mean, it's so conservative, so we can even implant from animals, right? So in order to induce and produce antibodies against collagen, it should be special tricks, right? So because of that conservative structure of collagen. Thank you. It's clear for me now.
Yeah, okay.
Okay, and then I see, Eddie, that your hand's up. Go ahead.
Yeah, so you talked about the kind of the follow-up of these patients that are now 6 and 11 years old, and you mentioned the positive outcomes of those patients. Were there any negative outcomes of those patients, or any examples of some patients that might basically be in a similar situation functionally as patients that weren't treated prenatally?
Yeah, good question, Eddie. So for, I guess I didn't quite clarify this, but for both groups, they both had really great outcomes and not so great outcomes. So some that, even though they had the prenatal operation, still were not able to walk at all unassisted. Whereas there's some children in the postnatal group that were able to walk completely independently by themselves. But it's just that ratio of more within the prenatal group were able to walk unassisted eventually. I don't think they saw any kind of relapse or any kind of weird complications happen between their 30-month checkup and now this Postmoms 2 study. That being said, they weren't quite able to reach everybody. So they didn't go into detail about why they weren't able to reach some or why they only had 161. So that could be something to do with that. But from what I could tell, yeah.
Awesome, thanks. I do have another question too. Sorry, it's been a few days since I looked at the article, but I don't remember did it mention anything about infection rates?
I think on one of the charts there was something about infection of the chorion, but I think that happened in like one woman.
Okay.
But nothing about the shunts getting infected or anything like that.
Okay. And sorry, last thing. During the time when you're looking at this information, are you familiar with any other conditions where this is, or intrauterine surgery is indicated or has become like a standard of care or frequently done?
I didn't look into that to see if there are any other things that it could be used for. But I think this is definitely on the rise, and hopefully sooner rather than later will become standard of care for this type of surgery. That would be something to look up, though, something interesting.
Awesome, thanks.
Dr. Kortz, your hand is up. Go ahead.
I didn't mean it to be, but I will say that you did a great job, Gretchen.
Thanks, Mike.
Subconsciously, it was meant to be.
Agreed. Any other questions for our speaker?
So actually, I do have a question. So besides the sample size being kind of small, what are some of the limitations of the MOMS trial, and what are the ways that do the Vanderbilt and the CHOP studies address those? And then what are things that future studies should be cognizant of in terms of lessons learned?
Yeah, so sample size is definitely a big one. Kind of like the one at Texas. Well, actually, going back to Vanderbilt. So I think some of these rates that we're seeing going down is one because of just increased experience, and they themselves, like the surgeons themselves, are figuring out what's going right, what's going wrong. I think a big thing that changed between Vanderbilt and the original MOMS study was the use of the electrocautery instead of the trocar incision. So I think that would be something to continue to look at if people don't want to do the 2-port technique at Texas. Besides that, I didn't see anything that could really be a big focus of change, or that could be a limitation besides the already stated the trocar or the 2-port system, and possibly getting into the Da Vinci using that or something similar.